practice in both Chicago and Naples. I opened up recently a practice in Naples, and I spend more there during the winter. So, so at least in the winter, mostly in the summer in Chicago. So I mentioned about thanking my mentors. This is myself with Rich Green, Dr. Richard Green. He's from Hinsdale, and he took me under his arm, literally, in 1996 when I started my continuum at the Institute, and he is still very influenced in my life. He's a mental father. So anything that you're hearing today, pretty much I'm just repeating the words of many of my mentors, and especially Rich. And so that's one of our students put together, and because they said I was doing really out of it. So blame Rich for anything. So as I mentioned, my journey at the Pankey Institute started in 1996, and I went there really to learn information. I thought that's what I needed to do. 11 years out of dental school at the time, and I had taken on a number of other what I considered very patient programs that were very technically oriented. And what I learned is that I couldn't really be the best technical dentist if I didn't understand the other things listed below there. So behavioral management of my practice and my managerial skills, and then life balance. You're distracted with other things continuously, it's pretty hard to focus on your work. So the Pankey Institute is the only place that I know that actually focuses on other work. So this is one of my favorite crosses of life. This is I was given a lot of books to read and taking a lot of courses that I found very interesting in personal growth, and it helps you understand yourself better so that you understand other people. And basically, if you're focusing on the right things, the reward you receive are more than you ever.
Dr. Warga, I'm
Yes.
so sorry. Just the audio is still, some people are having a hard time hearing.
Okay. All right.
I think if you speak a little bit louder and more directly into the mic, it should be okay. I don't know if you want to grab headphones with the mic attached to it.
How is this if I do this?
I think that sounds.
Is that better?
It sounds good.
Okay.
It's just I think when you move back, it buffers.
Okay.
A little. Yeah.
How's that? Good?
Sounds good. Yeah.
Okay. Sorry about that. You didn't miss a whole lot just about myself if you didn't hear it. But basically, I was just saying that the Pankey Institute is the only place that I've gone to where, other than to learn more about not just the technical aspects you need to learn to be good at dentistry, in particular, you learn about things behaviorally, managerially, and about balance, which allows you to become a better dentist. And so ultimately, you learn about yourself, which then you help your patients more about them, and the rewards are very gratifying. So the learning objectives of this class tonight is understand the keys for a healthy occlusion, understand signs and symptoms of pathology caused by malocclusion, understand how to determine the changes necessary to eliminate pathology for angles 1, 2, and 3. And I'm going to give you a hint right now that basically the changes necessary to eliminate the pathology for all of the angles classifications are virtually the same thing. Treat them a little differently, and it's just understanding why you need to, what you need to focus on. So keep that in mind as we go forward. And so the learning curve, and this is when I got out of dental school, I would say I was very unconsciously incompetent. I thought I knew everything, knew all the latest, greatest techniques and materials and whatnot. And So then as I started going to continue education and also failing at my trade, I realized that there were a number of things that were happening and I needed to learn more. I would just place composites and they could just be some occlusal composites, taking up a conservative amount of the occlusal table. And the patient would be complaining and I would be chasing around trying to speak and couldn't figure out why they were still having a problem that seemed to be occlusally related. When I prepped teeth, I would prep the second molar and I would go to my lab. Back then we had to make our own temporaries indirectly. And I would go to my lab, make my temporary crown, come back to the chair, and the patient was biting on the tooth that I had just prepared. And I know I had prepared it. Funny. Or if I took off a 3-unit bridge in the posterior, I would, the space was gone. And I was wondering what the heck is going on. And putting in crowns and then having to adjust them continuously and adjusting that crown, but adjusting other teeth in the mouth was just simply unhappy. I was having failure with my patients. And then I would be, first started, I would do my own root canals. And there were a time or two that I thought for sure the person needed a root canal. The tooth was so sensitive. And when I would the pulp out, it looked pretty much like a vital nerve to me. And the person came later. So it can be very frustrating. And so to commend all of you for your education and trying to figure out why people do have problems and how can you solve them. So we go from unconscious incompetence, consciously incompetent, which is something maybe I'll pull a couple things out of the air tonight that make you think a little harder. And then you can become unconsciously competent. And then when you've practiced the trade long enough and practiced this for many years, hopefully you do it as second nature. So I'll open up my chat box. I'd like to know, what do you see here? Such as is it healthy, unhealthy, and how old do you think the person is? So if anybody can type in, just put an age in there. Chat box. And if nobody says anything, that's fine. I'm not seeing anything, Desi, by the way, as far as me, except yours.
Nobody has written in the chat yet.
Okay, that's okay.
If you want to give them a minute, or in the Q&A, do you have access to the Q&A tab?
Yeah. Oh yeah. Okay. Oh, there we go. Yep. All right. All right. Midline shift. Disabled. Okay, the chat is disabled. Okay.
Oh, so everything will just come in through the Q&A tab then.
Okay. Very good. All right. Okay. So the age of the person I'm turning off my chat there. This person is 58 years old and she has a very healthy dentition. And the midline shift is more to do with the position of her jaw. It's actually not in a maximum intercuspation, but yes, there is a slight shift apparently there. But you look at the photo of the portrait, she is basically a class 1 patient and she's very healthy. And she did have some wear on her teeth and she was concerned about it. So she was basically a healthy class 1 person. So she asked me if I would just maintain her that way. Anyway, so occlusion. Let's talk about what healthy occlusion is, which in that patient is very healthy. And if we examine her teeth, you know, closure, all teeth contact evenly. And then when you close firmly, there's no deviation in any direction. And upon any excursive movement, no posterior tooth touches before, harder than, or after an anterior tooth. So that's what healthy occlusion can be. So the common keys are equal intensity occlusal stops. You want anterior guidance to disclude the posterior teeth as quickly as possible. And you want stable jaw joints. Some of the tools you need: armamentarium, an articulator. So if you're doing work in your lab, a FACEBO or facial plane analyzer, centric relation bite records, excursive records, and a comprehensive examination, subclinical and clinical. And I want to emphasize subclinical in that you need to be looking for things that the patient's not just reporting themselves. Prematus of teeth. Many patients don't realize that. Many people don't realize many things, exposed tendon, etc. Now I emphasize the airway. That's something that's become quite common in and I believe in dentistry, more so than any other health profession. And I would put a challenge out to all of you to make sure that you are getting involved in airway. The medical profession doesn't seem to pay as much attention because I think they don't know how to get paid for it. I'm not certain why they're not spending more time in it outside of the fees, but anyway, it's something that we are charged to do as dentists, airway, good at an early age. And there's many good courses on airway. Why centric relation? That's really, there are people that think it has nothing to do with dentistry, but I would tell you the circles I hang in and the type of dentistry that I'm looking to do is really a spot for me to understand. Don't think you have to always have every patient in centric relation or centric occlusion, but certainly it's something that you should understand, use it to your advantage. So you're born without teeth, and this is a Danar tutor that I use for my patient education. And the jaw joint is seated, the condyle is seated here. The muscles are relaxed and the jaw just hinges. So centric relation is the relationship of the mandible to the maxilla when the properly aligned disc assemblies are in the most superior position against the eminentia, irrespective of vertical dimension or tooth position. People go there anyway, with or without you. Doesn't have to be manipulated, and it's freedom and relaxation. It's no different than talking about any joint that, for example, your arm, you have a bicep and tricep, you have elevator and depressor muscles. Well, the jaw has that. And it's simply no more complicated than saying when your bicep is contracting, your tricep should relax. Unless you want to strengthen your bicep, then you would have resistance there. So those muscles work in harmony with each other. They're antagonistic to each other. The thicatory system has a similar arrangement around the TMJ jaw joint. So centric relation is the neuromuscular harmony of teeth, joints, and muscles. And so on the left of your screen is just centric relation without teeth, and on the right is with the teeth. So the jaw joint position, the condylar position, did not change. So predictability in dentistry for me is that I certainly would rather, if I were looking at these two objects, if I took one rock out of that pile, I wouldn't know how many other rocks would fall, and then try to put it back together would be quite challenging. And the Rubik's Cube block, you took one of those blocks out of there, you'd be able to put that exactly back together very easily. And that's kind of how I see occlusion, that a organized occlusion and an occlusion that has the what we're going to determine is healthy for an occlusion is a lot easier to deal with one crown at a time on a person who has a healthy occlusion that's in or restored to that point versus somebody who hasn't. So that's one way to avoid second molar crown or prepusecond molar in a patient with most terminal tooth, that you don't have such a significant shift in the. So anterior guidance is very critical, and that's with all angles classifications. If you do nothing but just work on your anterior guidance on any patient, and refine that, a patient will do much better. So it's essential to refine for stable, mutually self-protective occlusion. So in other words, the front teeth protect the back and the back protect the front. The anterior guidance should be non-restrictive to local function. You shouldn't have teeth knocked around after restoring cosmetic work on the front teeth. Not be that movement. The goal is to function and transition onto the most anterior teeth as soon as possible. And the force remain on the marginal ridges and incisal edges of the teeth. And we want smooth crossover, and we'll see some demonstration of that shortly. So here's a patient who had teeth number 8 and 9 restored. And when we do a right and left movements, we see nice, even contact on the front. So the patient can do that easily and comfortably. They're not having a difficulty in doing it. I explained to them, I want to see their teeth. They should be able to slide their teeth over each other as if they were in their stocking feet on a very highly varnished hardwood floor. So,
Dr. Warga, sorry to
yes.
interrupt one more time. There is a little bit of patchiness that is still happening with the audio. It's not bad on my end, but maybe just going through everything a little slower, slower and louder. Just
okay.
And then if there's anything that needs to be repeated, I'll just hop on and ask you to just repeat what you
Okay.
did. Okay.
All right. Yeah, I hear you very clearly and easily. It could even be, if it's particular to just a few people, it may be their own signal, but so.
Yeah, for the most part, it's coming through well. And in the recorded webinar that we will send out to everybody should be able to hear it fine.
Okay. So if we look at the 8 and 9 restorations, those are actually porcelain fused to a noble metal. Back then, that's what. Anyway, the lingual on the marginal ridges, you can see the starting there in the center. Very consistent, and it transitions to the incisal edges. So when we talk about pitch and bevel of front teeth, the leading edge of the upper teeth, the maxillary teeth, is the lingual. The pitch is the top. The trailing edge is the labial. So meaning as the person protrudes forward or goes in a cursive movements, those are the guide planes where the transition from. And on the lower teeth, it's just the reverse of that. The leading edge is the labial, the pitch is the trailing edge is the lingual. And there should be a very smooth transition as you go over these edges. It should be irregular and bouncy, very easily done by the patient. So talk again about the excursive movements. We have our centric stops, and in your class 2 patient and a class 3 patient even in a class 1 patient, you may have some guide planes on your molars or bicuspids even. And so as long as the stroke gets longer as you go forward, your anterior guidance, moving the guidance as far forward as possible. So I hope that is clear to you, that so it's okay to start on a bicuspid as long as you're not knocking that tooth loose, and then it can transition as you go forward to more anterior teeth. That's a way I make sure I can, that for fremitus, I take my fingernails and I put them on the roots of the teeth or up at the cervical collar, and when I have the articulating paper in the patient's mouth, I'll feel for that fremitus. If there is fremitus, then I know I need to do a little more adjusting. So this is things that I do with my patients and talk about. And I think it's important that the patients understand so that they can communicate with you. And so the one thing I'll always talk about is with centric relation, and to see where they're at and why do we want to focus on that. If we talk about a door fitting into a door frame, and I'll demonstrate that if I'm sitting next to this and open and close it into the door frame. And that's analogous to centric occlusion, that the door fits into the door frame. So the door is the mandible and the door frame's the maxilla. And if you have a discrepancy between the two with the door, the more times you open and close it, the more likely you're going to knock that door off the hinges, or maybe you'll damage the door frame, or maybe you'll damage the locking mechanism. So it's a matter of the mechanical arrangement plus how often do you use it and how hard are you using it. So one of the things you can do right now, and hopefully you can see me, and Desi, tell me if you can see me okay. I'll sit there with my patient, I'll take my mask, and I'll put my fingers on my masseters, and I'll clench my back teeth together. I'll show them that my fingers pop up. You can see my masseters bulge a little bit. Then when I change my bite to my front teeth, the masseters relax, my fingers go back in. And I have the patients do that. And so they start understanding what occlusal arrangement. So we want those masseters to relax as we go on our front teeth. Otherwise, our front teeth will get destroyed. And when our front teeth get destroyed, our back teeth will also start getting destroyed. So when a patient is exposing dentin on their anterior teeth, I encourage you all to protect that. I use a product made by GC. It's pronounced Genial, GCAENIAL, and it's very strong and it's a flowable, and I can cover small amounts of exposed dentin, and that protects that dentin from wearing down faster and saves that anterior guidance. So another thing that, and you can try doing this, but right now if you want, but if you stand flat-footed on your feet, that's analogous to having nice, even holding stops.
Dr. Warga, real
yes.
quick, going back to the material that you were just talking
Yes.
about, it cut out, I guess, when you said
Okay.
it, repeat it.
Sure. It's made by GC, and it's Anial, AENIAL. Okay, maybe you could type that.
Yeah. What was it?
AENIAL, and it's a flowable, but it's a very hybrid flowable, which is interesting. A lot of the competitors are out there trying to mimic this material. So it works very well on these anterior teeth to cover these exposed dentin areas. Minimal operation. What I was talking about now is the centric stops, and why we want more teeth to touch. If you're flat-footed and also talking about pitch of teeth, you want people to be able to have a nice, stable, easy to rest their teeth on, so that their muscles aren't being overactivated. So think of yourself standing on your flat feet. It's very easy to when you're just on your flat feet, but now go ahead and stand up on your tiptoes and see how stable that is. It's much harder to control that. You're activating more muscles to do that. It's no different than teeth and on the anterior guidance. So when the teeth are going over each other and going from those leading edges and trailing edges and then landing on the tabletops or the pitch of the tooth, top of the tooth, it should be very stable, and you should not see muscles gesticulating or having trouble stabilizing the bite in that position. So you want that to be very smooth and stable. So signs and symptoms of pathologic occlusion. This is not a complete list, but it's a very obvious list. So exposed dentin is certainly something you don't want. Hypersensitivity often causes exposed dentin, or hyperocclusion will cause hypersensitivity. Chip incisal edges, cracked teeth, fremitus / mobility. So again, fremitus, put your fingernails on those teeth, on those cervical areas, and you'll feel more refined changes in occlusion. And any person with TMJ pain and headaches, it's often occlusion, not always, but can be. and people with root canal-like symptoms and periodontal defects. So what do you see here? I'll pull up my Q&A again, just real quickly if anybody wants to get in there. And so I'll just move forward. You can see that there's deep fossae on both those second molars, on the first molars. So there's something is changing back there. And that is, if you look carefully, you'll see the longitudinal enamel fractures. You'll see the widening of the occlusal table. So when the cusp flaring out further, that's from occlusal wear. Generalized flattening of the cusp, deepened fossae, and dentinal exposure. So these are all signs of pathologic occlusion, and it's caused by plunger cusp. So if you look at that second molar, and I don't know if you can see my mouse. Can you see my mouse or not?
Yes, we can see the mouse.
Okay. So that cusp, and you can see a significant wear facet on the lingual aspect of the lingual cusp. That's a warning sign of too much contact on that tooth. So that plunger cusp is digging into that softened material. That's why you want to be careful with your restorative materials. You want to make sure that they're firm enough that the cusp don't dig into it and start erupting. So what do you see here? There's porcelain missing. There's a lot of dentin exposed. And so to understand what crossover is, picturing how these teeth end up looking like this. And so we even have what I would call a legitimate abfraction because the porcelain popped off on that cusp. So, and
Can you repeat that one
sure.
time?
There's a what I'd say a legitimate abfraction on number 11. I believe most of what people call non-carious cervical lesions are actually mostly toothbrush abrasion, well, really toothpaste use. And this particular on porcelain, though, you can see how that snapped off at the neck. So there's too much force on that tooth. And in general, I would just tell you that anterior restorations are the cause of that wear. So the occlusion is pathologic. When we go to crossover, we can see how there's just no room for that lateral incisor, that stress. So often in cosmetic cases, you'll see the laterals break. And if people aren't looking at crossover, they are not going to resolve the cause of the failure. So what we see here, a lot of chips. How old is this person? Now, when you see more chipping, usually the person's older, but this person is only 1. And when we look at what the cause of that chipping is, it's not from putting in the mouth, it's from severe incisal wear, stating what we see here. It's severe relative to the age of the patient. And as the person goes in excursive movements, you can see how these chips line up with the lower teeth. So there are styluses on the lower canine, and it's digging into these teeth. And people go in these positions when they're asleep. So the question to the patient is, when do you want to fix it? A lot of people don't realize they have these problems. And if you just let them go on and on, you're contributing to the demise of their posterior teeth as well. So the solution for here, again, was just using some composite, equilibrating those edges, creating proper pitch so that there's landing areas for those teeth to touch on each other without the muscles being hyperactive. This woman came in and she was complaining of root canal. And a colleague in my neighborhood sent her over because he had seen her a number of times and had been sending her to the endodontist. And this was the 4th, 5th, 6th time she came in with the same complaint. And every time she went to the endodontist, she had a root canal done. And so here we can see there's 4 of the root canals there. And typically when you see x-rays like this, what do you expect to see on the other side? Typically the same thing, but we don't. So there's your red flag that, well, maybe something else is going on here other than that she needs the root canal, because now here she is with this complaint. And even after all these root canals, she was in her mid-40s when I met her. So when we look at her maximum intercuspation, we say, oh, well, we've got some coupling of the front teeth. I don't see a lot of pathologic wear or anything. So let's see what she looks like in centric relation. So I have these very readily accessible in my office, and I give these to the patient, and she was in pain when she came in, and I put this little button in her mouth. That's a little compound in that. Today I use like a bite red material, this heated material, and the patient down, and I let them relax a while. And so the picture on the left is the centric occlusion, which is the arc of centric relation, and she's touching her teeth at the first point of contact. And we can see a significant discrepancy between that position and where she squeezes her teeth. So she's got a door that doesn't fit into the door frame too well. And so within that time, and here we can see the models demonstrating the same thing, see how significant that is. And it's something that if just review on the schematic, we can see how the jaw, the red dot is the position of where the jaw joint would be seated normally and the point of relaxation or centric relation. And we can see how she slides forward. And on this schematic, you can see how the back teeth touch first before that happens. That's aggravating the muscles. And so she's got have harmony with the muscles, with the elevator muscles being able to close when the depressor muscles are relaxing, and vice versa. You have harmony. In this situation where you prematurely hit a back tooth, you are actually having to activate depressor muscles, move it forward as you're closing. So you've got hyperactivity of muscles or disharmony. And the reason why she was experiencing pain is because these muscles were getting so hot from that hyperactivity, it referred to the teeth. And this trigger point manual is, the thing must be, probably weighs 20 pounds if you ever see the book. It's incredible. And Janet Travell and David Simons did this study on pretty much the whole human body. And so for dentists, you should understand that muscle pain can cause root canal like. So a solution for this patient for the time being was put a splint in her mouth. She actually had a mouth guard, but it wasn't adjusted to this position. So I used her existing mouth guard and I adjusted it, and that was her treatment. I did not do anything more, and she did not need another root canal, or has she had one since that day, which was over years ago.
We did have a question pop up in the Q&A.
Yes. Okay.
If you wanted to make sure.
How do you analyze the need for long centric? Okay. That is a long centric would be sliding from a CR position into a maximum intercuspation position. How I interpret that. And it's okay as long as the muscles aren't, there are many people who can be in the same condition as this woman, but don't experience the discomfort. How do they do that? Or why doesn't it happen to everybody? Because she doesn't stress the system as often, or a person who doesn't. So I do want my, what you'd call long centric, as smooth as possible to get them. I would call that a transition of anterior guidance. Anterior guidance can start on the back teeth. So just because the word anterior is there, doesn't mean it's anterior teeth. It can start on posterior teeth and transition forward. So that's how I would describe what I do with long centric. So I use a lot of splints, and I use different types of splints depending what I need to. And so this schematic shows that it's occlusal muscle pain for that patient. I was able to just put an anterior deprogrammer in her mouth, and her pain went away. Within 10 minutes, her pain was gone. That she came in with that root canal-like pain. If I need to do a restorative verification, I want to make sure that I have a full occlusal splint and make sure that I can see that the markings on it are consistent over a period of time. And if I want to really change an occlusion, I'm going to design what I call a Tanner splint, which has more anatomy in it, even though it's still a plain splint. All of this that I'm talking about these are courses and courses of understanding these techniques. And I would encourage you that the Pankey Continuum, that you learn many of these techniques. But today we're just kind of the generalized simple discussion. So Engel had a classification and he called class 1, as we see on the right. And what's so good about it is that as the patient goes in lateral excursions, the mandible is projects forward. So you're relieving pressure on the TM joints. Okay, so as you go in excursive movements, that's what makes a class 1, a healthy class 1, I should say, occlusion work. And a class 2, well, the same thing should happen, that the mandible is not restricted as you go forward. If your canines, now your lower jaw is hitting on the distal incline of the maxillary canine. And if that tooth was restored or orthodontically moved into a position that was more traumatic, it would push the mandible back. So you have to be very careful in restoring front teeth in a class 2 patient. I would say just in general, a class 2 is a more sensitive patient. So why is class 1 so preferred? To me, it's just simpler to work with. It's not a better occlusion, it's just simpler to work with. Class 3, as many of you who have practiced for a while know, that class 3 patients often don't show a lot of signs of occlusal disease. Not, considering that they don't have anterior guidance, it's quite remarkable. And many of them compensate in ways, and many of them haven't been, if nobody's done a lot of dentistry on them, well, that's part of the reason why they're doing so well. So we'll look at this little video schematic of what a healthy relationship of the muscles is. And when the red comes up, what that's showing is the muscles that are being activated. Here you have hyoid, and then when you go, that's the initial opening. And then when you go into translation of the condyle, you have the inferior belly of the lateral pterygoid up by the jaw joint. And on closure, the elevator muscles start working, and you have a very good harmony of these muscles operating. Okay. Now, when we go to a situation where we don't have harmony, it's gonna hurt. Here we go. Okay, so we have in this situation, we have a disharmony of the muscles because we're not in centric relation. That joint isn't seated in this position. Those green lines represent position of condyle relative to the joint. I should just say the condyle is not seated. The condyle is not seated here. We have firing of elevator muscles and depressor muscles at the same time, fighting each other, combating each other. So now we get some hyperactivity of these muscles, and that can cause pain and or damage to the teeth. And so if we put a splint in the mouth and it helps the joint seat, so I'll play that again, go back a second. The splint has to get the joint seated. Right here, the joint is not seated by those green lines. Condyle, I keep saying condyle is not seated. As the splint is adjusted, and we'll watch this adjustment, condyle starts to seat, and when you get it all the way back to where it should be, then we can get the muscles. So good splint therapy gets the condyle seated properly. And again, splint therapy is a skill I would encourage you to this is, if there's anything you're really paying attention to right now, these keys that I'm showing you here are the things that for all angles classifications will help you. Distalizing forces, enclosure or excursive movements. You have to be able to identify that. Anything that moves the condyle in a back position, that pressure into distal compartment of the distalizing force. So it could be an overbolt lingual of an anterior tooth, and you're pushing back. It could be that the person had orthodontics and their anterior teeth were retracted too much, and that would be distalizing force. Steep inclines, when you make these too long, you're interfering with the natural envelope of function where the person wants to go. You're causing restriction of those muscles will be reactive. You have deviation unilaterally on closure. So the person who is not normally seated in centric relation and they close and they deviate to one side, that typically is putting more pressure and strain on one of the jaw joints. That's a patient that's going to have more trouble than a person that moves equilaterally on both sides as they close. So an interference to the path of closure in the arc of centric relation, it's one of the more common things we'll see. Lack of appropriate anterior guidance, meaning that the front teeth are not discluding the back teeth enough. Get the back teeth to be lighter than the front. Sleep disordered breathing. It is very common for people who have sleep apnea and other sleep disorders that they grind their teeth in their system more. So that's something to make sure you're treating. And then, of course, there's selective serotonin reuptake inhibitors. So people on happy drugs, they more muscle activity. And then there's, dentist caused problems, cosmetic dentistry and orthodontics, which I've alluded to. So when you do equilibrations, this is just a very example of what you should be looking to do when you're getting teeth adjusted. So we have here on inclines, and we want the centric stops really to be in the central fossa and the cusp tips and on the marginal ridges. So where do you adjust? If you adjusted the incline, and I'll take my mouse here, of the maxillary tooth, adjusted that, you're really digging a hole in the tooth and creating a steeper incline. So in this situation, you really want to polish or adjust the cusp and warp that cusp so that you're moving that point of contact toward the central fossa of the upper tooth.
Dr. Warga, the
Yes.
ending of what you were just talking about was very clear, but when you first started, it was a little spotty with the audio. Do you think you could just touch on the beginning of this?
Sure. So when this is just a simple demonstration of a single tooth of how to decide, do you adjust the fossa when you have a contact that you don't like? You have a incline. So for example, this particular situation, contact started on the incline, and you could say this tooth had fremitus, and you want to get a nice centric stop on that tooth. So you'd rather be in the fossa, the fossa of the tooth, or on the marginal ridge. And so your choices of what to adjust is either the cusp tip or the fossa. So you want to adjust the cusp tip by warping it, because you're moving that contact onto the marginal ridge and off of the incline. It's more conservative to do that than to dig a hole in the maxillary tooth, deepening the contact point. So here we move it, and so the contact, the maxillary tooth, more that marginal ridge. So angles class 1, why is it so popular? Well, 1899, the journal of the day, very well read, and one of the only, if not the only, the Dental Cosmos angle defined what ideal occlusion was. And he said it was class 1, and anything but class 1 was malocclusion. I will disagree with that. Just simply say there are many healthy people in class 2 and class 3. So in of itself, it's not evil. So there, there's certainly a lot of room for debate about these things, but anyway, the conclusions about about occlusion, that there's not a precise and clinically meaningful definition of malocclusion, does not exist. Okay? The occlusion literature is you can read whatever you want into it, and I will just leave it be that class 1 in of itself is the only healthy occlusion. And as I alluded to, that class 1 is very nice to use if you have it, but it doesn't have to be class 1. So this is a good friend of mine, Dr. Todd Davis. He's in Atlanta, but that golf swing looked horrible for you golfers, but it worked. And similarly with occlusion, it doesn't have to look great, work great. You have teeth that look very irregular and yet be healthy. And I'm going to read through some of this literature very quickly, but basically it says it supports more group function, and that there's not any one type of occlusion. And I'm happy for, if anybody wants to bring any articles and talk about them, you're welcome to send them to me, and we can take them apart and find out why they're saying what they're saying. So balanced occlusion, I just want to emphasize this, that you can have non-working side contacts that are in healthy occlusal arrangements. Because it's on the non-working side does not mean it is an interference and needs to be taken out. So when formulating a treatment plan for a patient, we like the patient the way they are, meaning don't do a lot of changes when the patient's healthy. So evaluate the health of the patient, not just what type of occlusion they have. It means it's more important to know what the health is versus if their angle is class 1, 2, or 3. So if they're healthy, don't change it much. You know, you might need to refine the anterior guidance. If the patient does have pathologic signs or symptoms, splint therapy is a good start, and it allows the patient to experience alterations in a reversible manner, and what you can choose if you want to alter the angles class, and you've tested it out. So this is just a laundry list of what I basically do when I'm trying to evaluate a patient. So know your patient. So I like to ask, to understand what the patient wants from me. And we saw earlier, I said, so what do you want about your teeth? You got very nice, healthy teeth. She said, in 5 years, 10 years, 20 years, she wants them to be the same. Well, here I am well over 20 years later, and I can tell you she was just in my office the other day. I took pictures. I didn't put them in here, but she looks as healthy as ever. And so a comprehensive examination, you need to be thorough in this evaluation so that you can have the proper record. So when you're doing your treatment planning, you should learn to be proficient in using these instrumentation. So and testing your changes in a reversible manner is very helpful. You also can test to see how sensitive a person is, which was a great thing for me because I always wanted to have my foot on the gas pedal and start getting patients treated. And then there were some people I wish I had never touched. Well, the splint helped me slow down and learn more behaviorally about the patient. And so you can, in a class 1 patient, you're going to make a class 1 splint, meaning I'm looking at what they start with and their front teeth are coupled in a class 1. And so my splint design has them coupled. I'm not going to change that. They will still be coupled at splint. Now, on the right of this, you'll see where I basically erased out part of that splint. That would be a class 2 splint. So if I made a splint like that and the patient got healthy, I'd be like, well, they can be a class 2. I don't know why I'd want to change them to that, but maybe for some cosmetic reason. Or class 2 patient, as that's what the patient on the left is. You can see the anterior relationship that's open. It's a slight class 2, div 1. And so the splint that I'm designing to take care of any discomfort is a class 2 splint. And if I had filled that in, as demonstrated here, that white there, now I'm testing a class 1. And if I was restoring that patient and I put a class 1 splint in the patient, I would want to restore the patient in that same occlusal relationship as the splint. You can test out different classifications with your splint therapy. So here's K. We'll get into some cases, and this is we have several cases, and in the next 10 minutes or within that, we'll get through these, and you can see how this gets in the mouth. So K had significant pain. Her teeth were virgin. She was 16 years old. She had been in orthodontic treatment for 3 years, and she had significant headaches and couldn't chew food. Her teeth were nothing but sealant on the maxillary and mandibular, very healthy. So her maximum intercuspation on the right and her centric occlusion on the left. We have a significant hit and slide. And so I made her a splint, and I created the anterior guidance so that her posterior teeth occluded. Her splint looked like this. And so now we can transfer what I learned from the splint to her teeth. So if we look at that, we have some red lines on the bicuspids. So there is some functional lateral guidance on these bicuspids. And so I transferred that information to the teeth. And if you look at the upper bicuspids, you'll see there's composite that's in those teeth. And on the lower first molar, I also filled in her occlusal table on tooth 19, lower left, to give her an occlusal stop. And that was her treatment, instead of going back to ortho or mutilating her teeth with aggressive equilibration. And so here we can see that transferred learning from splint therapy to the teeth, and staying with very conservative treatment. Splints don't always have to all look the same. This patient, a very deep bite, and she had some occlusal muscle pain, and that was her splint. And I worked with the muscles. I'm not worried as much about the dots and lines. They tell me what I should be looking at, but I'm more worried about what the muscles are doing. And so the class 1 splint, which is in hers on the right, it's very similar in design to a class 2. The dots and lines are different, that's all, but they both work. So here's Peter, and Peter, excuse the unfocused picture there. Peter he could not see his teeth. They were wearing down. He was in his mid-40s, and he has one of the most interesting bites I've ever seen. And he is not upside down on the top picture there. That's his bite, and he's got some retained primary molars, or ankylos. So his centric occlusion is on that lower left of your screen, and where he chewed. I'd asked him where he chewed. Well, you can see by the wear on his teeth, he chewed on his front teeth. Quite amazing that he could do this. Well, he didn't want to have surgery. He wanted to be restored, and he was told that I knew a little bit about how to handle funny occlusions. So that's his model work, and that's his centric occlusion. And so that's his vertical position in centric. And I looked at that and I said, boy, that really gives me room to put some teeth where those ankylosed teeth are. I wonder if he can tolerate that position, because that's quite a large opening to be. So I'm thinking out of the box a little bit, instead of just working with his existing vertical dimension. By the way, my son and I were ready to play chess, and my daughter came around and put her little Polly Pockets on it. So that's thinking out of the box. So I did a little quick wax up on this, and went, well, I think I could maybe make a splint there and see how he does. So I had him wear this splint, and he said he was perfectly comfortable. I even had him eat with it. Said, well, it wasn't easy to chew with, but so he didn't really wear it often for eating, but he was able to wear that. I said, well, let's give this a go. I think this might work. So I went ahead and prepped his teeth. I had some implants eventually placed in the edentulous areas. I used his temporaries as a splint. He had no splint then when he had these. It was just his temporaries. He was doing great. So we were waiting to commit to final restorations to know that everything was comfortable for him, and he was loving it. And so we went to final restorations, and Peter's a very happy, non-surgically treated patient. This is Steve, and I didn't have a pre-op picture, so I actually took a back, kind of knocked out his teeth there. So anyway, you'll see his teeth here. They were very worn. Steve also had a significant underbite, class 3 or stroke class 3. And so we did the same type of evaluation, and I looked at Steve, and this is actually where he was at centric occlusion. So he's edge to edge, and that's a retracted view of the thing. And so I went through the same type of process with Steve and said, well, he needed restorations on his teeth no matter what. So I didn't go with a splint therapy with Steve. I just went right to prep and use my temps as the splint for Steve. And that's his lateral view with his temporaries in, and his chin's actually in a better position. His profile has improved because his chin is now in a more retruded position. And we went to final restoration. So obviously there were a lot of steps between all this, but that's not what we're talking about tonight. So I just wanted to show you that both these people were told they needed surgery to get their jaws fixed, and neither of them needed it. And it was just using centric relation as my starting point. That was the key to solving these cases, so that you understand what you can do with centric relation and vertical dimension and know how to handle anterior guidance. You can create healthy people. And here's Steve before and after. And there's Steve. And so a couple quotes here to close with from Napoleon Hill: the man who does more than he is paid for will soon be paid for more than he does. So give away some of your treatment and try to help people, and they will help you. So thinking of the Pankey motto is quid pro quo. Think about giving before receiving. And people who want to achieve more, there's less people that you're having to compete with. And if you have goals, you need to have deadlines for those goals. And don't wait, the time will never be just right. And just a little, want you to know, by the way, this was recorded. I hope the recording is better than some of the audio some of you had, but and you'll receive it via email, and so you'll get your CE letter of credit. And the Pankey Symposium is one of the biggest CE events of the year, and it's coming to Scottsdale, Arizona, September 15th to 17th. There are 9 featured speakers with a variety of topics, all surrounded around top-tier aesthetics. Take your phone out right now if you want and scan the QR code on the screen, or Desi will put the information